Show. Again. Oh, please. All ready? Okay, sinus rhythms. Sinus rhythms is, you want a normal sinus rhythm. That's what we hope everybody, what did you do to your hair?
Well, I take my head off.
Yeah, thanks. You look like a smart guy here that's going to go up like that. A rooster tail. So sinus rhythm is what we want to have all the time. We want to have a normal sinus rhythm. So we're going to look at the sinus rhythms, the fast sinus rhythms, the slow sinus rhythms, and move forward from there. Now, I've given each one of you a clicker, and for those of you that haven't used these before, when we get to a slide, it's got a little blue star on there. That means the next slide is going to have a question. So make sure you have access to your clicker, that you not put it in your book bag or your back pocket or something. And if you look on there, it's got 1 is A, 2 is B, like that. So I think they're numbered either A, B, C. I think they're A, B, C, D. So you just select the right one. Now there should be 25 of us in here today by the time we're all here, but it should have a running total up here, so I know when just about everybody's clicked in. So if you get it wrong, that's okay. We're going to embarrass you. No, we're not going to embarrass you, but do that because it's a good learning experience for you. Our objectives, we're going to be looking at the origin of sinus rhythms. You already know? No. The origin of sinus rhythms. We're going to look at the electrical components of sinus rhythm. These are all part of your A&P that you should have already had, so we'll probably go through that fairly briefly. We're going to look at recognizing sinus rhythms, recognizing sinus brady, tachycardia, and sinus dysrhythmia. Does anybody in here know if you have a sinus dysrhythmia?
I drink enough Red Bull. I drink enough Red Bull.
That's probably not sinus dysrhythmia, it's going to be tachycardia.
Just a little bit.
Anyway, and we're going to look at sinus arrest and the clinical significance of these. And one thing you probably, I'm sure Nick's already talked about, we're going to be treating your patient, not the monitor. So you may see something weird on your monitor. If your patient is alert and oriented, vital signs within normal limits, don't be freaked out. So we're treating your patient and not your monitor. Okay, the origin of the sinus rhythm. When we name a rhythm, we're going to name it based on its site of origin, where it's initiated from. So in our sinus rhythms, where's the rhythm's going to be initiated from? The SA node. That's correct, right here. And that's a good thing. So anything we call a sinus rhythm, it's going to initiate right there. What's the default rate for the sinus node? 60 to 100. When I say default rate, that means what's its normal rate. What's the default rate for the AV node? 40 to 60. How about the default rate for the bundle of His? 20 to 40. And that's important, so make sure you remember all those guys. I forgot to fix that. Now we're going to talk about some verbiage. Inherent rate, intrinsic rate. That's what we're talking about when I say what is the default rate. That means the same thing. So the intrinsic rate or the inherent rate is going to be what you're going to have at the SA node. Okay. Did I go too fast? Don't vote yet. Okay, so I already said for the sinus rhythm it's going to be initiated in the SA node. And it's going to move from the SA node through the atria, through the internodal pathways. What that means, and I think there's some drawn on here, you can see these little blue lines. It also goes over to, what's this chamber right here? Well, the what? The left atrium, right. So it's going to innervate that also. You know that both of the atria contract at the same time. Both of the ventricles contract together at the same time. So as the impulse starts here, it's going to be spread throughout that. And there's almost like a little pause there till it's all innervated so that it goes all at once. It doesn't like, as it gets here, it fires, here fires. So once it gets everywhere through there, it's going to fire. And so where are all those impulses regathered? At the AV node. And how quickly does it move through the AV node? Yeah, it's going to take a short break in there to collect everything. What's happening during that little break before it? Yeah, it's going to allow the filling of the ventricles. So before it shoots through, it's going to allow the ventricles to fill with blood before it fires. So the internodal pathways do what? Yep, they provide the innervation or the electricity, if you will, throughout the atria. I already said that. All right, here's your question. Chop, chop. Electrical stimuli travel through the atria via the come on. I got a few more out there, so hit yours again. Somebody's sluggish. We got more than 19 people in here, don't we? Got 20. That's good enough. All right. Oh, who missed this? Yeah. Internodal pathways. The question says through the atria. All right. Good job. Somebody was listening there. Okay. Once it goes through the SA node to the AV node, it's going to go to the bundle of His. What happens at the bundle of His? Where does it go then? Yep, it's going to go to the left and right bundle branches. So we'll learn to recognize the bundle branch block as we go through here. And it's going to be split, and it's going to go down through the bundle branches to, what do we call these little hairy things at the bottom? Those are the Purkinje fibers. And so as the impulse travels through, it's going to be held up until it's innervated everybody so that it pulses at one time. Now, as it fires, does it fire from the top up here, the middle, the bottom? Do you care? Just all goes at once? Yeah, it goes from the bottom up. It's kind of like you squeeze a toothpaste. So it squeezes from the bottom up so that it shoots out. Good job. Have I told you anything you didn't know yet? Good. Okay, this is just a little diagram of how it goes. The SA node, through the internodal pathways, to the AV node, to the bundle of His, the bundle branches, and then the Purkinje network, or Purkinje fibers. That'll be important. You'll see that again, probably not in this form. Okay, we've talked about the pacemaker sites and what the intrinsic rate is, right? We can pass that up. So far, we've gone through things that you already know, right? No new knowledge here, so the people that come in late, they can't be mad because we're just reviewing stuff. Okay, so the only sinus rhythm that is normal is a normal sinus rhythm. So when you talk about a sinus rhythm, if it's normal, meaning it meets all the parameters, you're going to call it a normal sinus rhythm. And we usually just abbreviate that, you know. So if it is between 60 and 100, the P wave is upright, and like all the other P waves. What's the other parameters for it to be a normal sinus rhythm? Go right down here. The rate has to be what? 60 to 100. The rhythm? Regular, very regular. How about the P wave? There are two parts of P wave. That's why I put two. They must be present. They must be upright and uniform. Yeah. PRI? What's that? PR interval. What's it got to be? I wrote that in the wrong place, didn't I? Yeah, it's got to be 0.12 to 0.20 before what? What does that mean? Yeah, so the PR interval is, what is all does it encompass? The P wave and up to the beginning of the QRS. That's going to be the PR interval. Okay, so we know the PR interval meets these parameters. What about the QRS? We've got two parts of the QRS. They're what? To be a sinus rhythm. Yeah, it's got to be less or equal to 0.12. They have to be present and they have to be uniform, regular, so to speak. That makes a normal sinus rhythm. So if you have any ectopy, you know what ectopy is? Any funny little beats in there, any strange things that don't fit with your normal sinus rhythm. Say you go along, you've got 50 beats, and then you have a QRS, a PVC or something, and then it picks right back up. You would call that a normal sinus rhythm with PVCs. But you have to say normal sinus rhythm. If it's normal, actually, it would be a sinus rhythm with PVCs. But for every single rhythm, early on, I want you to go through these 5 steps. Make sure you look at both of the things associated with a P wave and both of the things associated with a QRS. And that's going to train your eyes to be looking for the specifics that go with that rhythm. Now, when I look at a rhythm, I don't do that anymore unless I can't figure it out. Then I'm going to go back and go through each one of those steps. But if you'll start out going through those steps, and that's what you will be doing in your workbook. Were y'all doing that last week? Yeah, y'all were doing that, weren't you? Yeah. So I want you to do that. Okay. Yeah, so in a normal sinus rhythm, the SA node is doing what it's supposed to do, and all the internodal pathways and the electrical system works the way it's supposed to work. So that makes it a normal sinus rhythm. I don't know if we go next. Okay, here's your question. Which of the following is the normal conduction pathway? So this will take you a minute. You need at least 20. You should have 21, I think. 21. All right, going on 20. Ta-da! Good job! You can read. You're listening. I love that. Okay. So, the heart rate for a normal sinus rhythm, the default rate, intrinsic rate is what? 60 to 100. So you can have a slight variation of that, but not much at all. The P wave always precedes a QRS. The QRS complex is always less than or equal to 0.112. The rhythm is a normal sinus rhythm. If they meet all 5 of those parameters, it's a normal sinus rhythm. Same thing again. And I have a couple really good charts I'll put on the website for you that should help you with some rhythms. All right, let's see. All right, I want you to look at this rhythm, figure out the rate, go through the 5 steps there, and then I have a question after that. You can see the little blocks, so you should be able to get your PR intervals. Got it? What's the rate? Rhythm. Regular. P wave. It's upright and uniform. It's present. PR interval. What? 0.16. Okay. QRS. What's the shape? It's tight, normal, upright, and what's its interval? Yeah, I think so. All right, let's see what our question is. Identify this rhythm. Go through the 5 steps. Now, y'all learned how to march these things off in prior weeks, so come on, a few more of you, take a stab at it. For those of you that pick normal sinus rhythm, you got to look at this thing. Now this is, see the dark thing here? You're only counting a 6-second strip. So if you counted this part as part of your 6-second strip, you missed that.
I can't see the lines.
Huh?
I'm depending on lines. I couldn't
That's
see
okay. There's a line. There's a line. I think, is that one?
No.
Somewhere in here.
That's what those mean.
Yeah, so we counted off 6 complexes, but this is more than a 6-second strip. So make sure you look at that when you make your decisions, when you're trying to figure out what it is. This is sinus bradycardia because it only has 5 complexes in a 6-second strip. So anyway. All right, sinus brady. When we're talking about sinus brady, where is the impetus? Where does it get its energy from? From the AV node? SA node? It's usually with the SA node, but some things can depress the SA node so that it doesn't fire at its intrinsic rate. So we know Brady means slow, but for whatever reason, the SA node, because it's a sinus rhythm, right, that means it originates where? In the SA node. So for those of you that said AV node, then it wouldn't be a sinus rhythm, it would be a junctional rhythm. So it was a sinus rhythm. So that one thing that takes it out of the parameters where the rate is too slow, if the rate is too slow, it's not a normal sinus rhythm anymore, right? Yeah. Did we get everybody back? Who? Oh, yeah.
My son's name, bro.
Why did you say that? I'm going to change your name to Rob then. Okay, so that one thing takes it out of being a normal sinus rhythm. And that's important that you remember that, because normal sinus rhythm means that all 5 of those parameters are within normal limits. If it's too slow or too fast, then it's not a normal sinus rhythm anymore. It's just a sinus rhythm with whatever it is. So in this case, it's sinus bradycardia because it was too slow. So anytime its underlying rate is sinus, you always want to call it sinus. And how do you recognize that it's a sinus rhythm and not a junctional rhythm? The P wave is the biggie. If you can see a P wave, a normal P wave with a normal PR interval, then it's going to be a sinus rhythm. Okay, there are some things that can cause your patient to be bradycardic. Can you think of anything that can cause your patient to be bradycardic? Because you read your book. That's why I know you know this. Do what? If you're hypoxic, yeah, if you're on medications like beta blockers, what else? Calcium channel blockers, what? If you what? Yeah, if you have a vagal stimulus. That's true. If you're like a highly trained Olympic athlete, it may be slow. What about heart disease? Disease in the node? Vomiting, hypoxia, hypothermia can cause bradycardia. I'm going to have to move you guys back there. I got a seat right up here for bad people. Any bad people, I'm going to move you right up here. Just raise your hand. Come on forward. If you're what? If you're decompensated? If you're in shock, is that what you're saying? Yeah, if you're decompensated, we're usually going to see tachycardia unless you're like FTD, and then we may see that. Morphine, and morphine's something you're going to be giving. It's a respiratory depressant. It also depresses the central nervous system, so it may depress the SA node. So anytime you got sinus brady, you need to see if you can figure out the cause of that bradycardia. Hopefully you can fix that. For some people, as we just mentioned, it may be a normal thing for them. Y'all know Tim Curry, he normally has between a 48 and 52. I mean, if it gets up to 58, I'm thinking he's tachycardic. So some people it may be normal. You may ask him if you can't find any reason for it. Is this normal for you? Yeah. Okay, here's the little sheet if you're interested about sinus brady. The only thing that's different between a normal sinus rhythm is the rate's going to be less than 60. So you need to make sure you count off the right number of blocks so that you've got a 6-second strip to look at so that you don't mess that up. Okay, look at this one. We know this is sinus brady, right? The rate is 40. Okay, and you know it's 40 because it's a 6-second strip, right? What's the rhythm? How do you know it's regular? Yeah. If you have a good eye, and some people do and some people don't. Some people can look at something, they can tell it's one block off. If that's not you, you need to be measuring those things off. The P wave is upright, present. The PR interval, that's pretty tight. I mean, that's a pretty close one. A QRS shape and length. What's the shape of it? Yeah, it's upright and tight. Tight is good here. Okay, which of these could cause sinus bradycardia? not an oral test. Okay, a couple more. I'm missing a few. Oh, good, 22. That's our highest number yet. We should have 22. Whoa! That means y'all knew what that word meant. How great. Good job. What is that? Yeah, it caused you to vagal down. That's correct. What is it about vomiting that can cause you to Brady? Yep, it stimulates the vagus nerve. What else do we do to patients sometimes that'll stimulate the vagus nerve? Yeah. What's something we do that we don't want them to Brady down, but we do it? Suction, yeah. If you suction them too aggressively, you're hitting the back of their throat, you may cause them to Brady down. Do we see that more commonly with adult patients or pediatric patients? Pediatric patients, okay. Just checking. All right, let's look at sinus tachycardia. Tachycardia means, this is where you say fast. Okay, there you go. Where does your sinus tach originate from? What node? SA node, because we call it what? Sinus tachycardia. That's right. The only difference is going to be the rate. So if you got those 5 parameters, the top one, the rate's going to be too fast. Now, there's always discussion about the top limit of sinus tachycardia. And I've got 100 to 160. Most commonly, after it gets above 160, you'd lose sight of the P wave. But if it's 170 and you can see a P wave, then it's what? It's sinus something. Yeah. So we don't, SVT is like a big term that a lot of things come under. But if you can see a P wave, it's sinus tach. And I have a strip I'll show you guys one time if I remember to bring it up that'll shock you. Okay. So if you see this on a test, it's between 100 and 160. However, if you can see a P wave, it's a sinus, a normal shaped P wave. Okay, what can cause sinus tachycardia? So if you're taking stimulus, yeah, stimulus. Yeah, if you're exercising, that may cause you some sinus tach. Where is it stimulus? Pain, anxiety, fear, what? Yeah, was there some significant sinus tach this morning? Yeah. Cocaine, yeah. It's going to probably go beyond sinus tach. Coffee, and that's one thing that I think a lot of people don't think about. If you've got a patient and they've got, sinus tachycardia, or they've got ectopy, where they've got PVCs and things of that sort, very commonly it's due to stimulants. I've talked to a lot of students that say, my heart's racing. Well, it's all that coffee. Yeah. I had a guy, the guy that works here, that came in our class last night because he was feeling funky, and we took his blood pressure and checked his pulse. I said, well, you've been drinking a lot of coffee and stuff? Well, no, not really, but I had a couple of Mountain Dews. Really? You think that'll cause that? Sure enough. Okay, sinus tach can also be as a result of hypovolemia. If you're shocky, you become tacky, right? CHF, severely dehydrated. Severe dehydration is also what? It's going to make you shocky. Yeah, and an acute MI, myocardial infarction. All those can lead to sinus tach. Now, sinus tach in itself is not real scary. What are we going to be looking at to decide how bad our patient is? Our patient, yeah. If they're real symptomatic, I don't care what the rhythm is. All right, here's the little chart on sinus tach. So you can see the only difference is going to be the rate, 100 to 160. Hey, what about if you have a 3-year-old and he's got a heart rate of 110? Is that sinus tach? No? It's over 100, isn't it? Didn't I just show you the sheet? It's over 100? No? Yeah. No, if it's normal parameters for their age group, then we're not going to call it sinus tach. So hopefully you deliver a newborn baby and it's tacking along at 150. That shouldn't freak you out, right? Okay, good. So everything else is normal. Everything else meets the same parameters. Only difference is going to be the rate. All right, look at this one. See, what's the rate here? Yeah, for this, I'd take 120 or you know, it's getting up to 130. What's the rhythm? It's regular. You know, and here when I say rhythm, I'm looking for, you know, is it fast or slow pretty much, sinus tach, sinus brady. Later on, as we get a lot of other rhythms, I'll have a sixth space at the bottom where I want you to identify and correctly name the rhythm. Like for a sinus rhythm that meets all those parameters, what are you going to name it? Normal sinus rhythm. If you just put sinus rhythm, it's going to be wrong. So if it meets all 5 of those parameters, it's going to be normal sinus rhythm. Okay? So you can have a sinus rhythm with, you know, sinus brady. That's a sinus rhythm. So you've got to identify it right. All right. Sinus tachycardia originates in the. See how we're doing here. Who put AV node? Somebody did. Make sure you look at your little thing, because sometimes I had a girl yesterday that had it upside down. That's correct. It's SA node, hence sinus tachycardia. All right, next rhythm, sinus dysrhythmia. That sounds a lot worse than it really is. Sinus dysrhythmia is basically what we would call a normal sinus rhythm, but it's slightly irregular. Remember I said there's that little 10% window there? Who would most likely have a sinus dysrhythmia? With a sinus dysrhythmia, you just have a little variation. If you look at the QRS complexes, you might pick up just a little bit of variation, but not much. Otherwise, everything is within the normal limits. What can make that be variable? It probably wouldn't be named a dysrhythmia, because that'll do some other freaky things for sure. What can make it slightly irregular? Oh, come on. What happens to your heart when you take a deep breath? It applies pressure to your heart. That kind of alters your rhythm just a little bit. So it's not unusual for people, if you take a deep breath, to have a slight, variation there. So for sinus dysrhythmia, it's only slightly irregular. And it says, if y'all read this part, it may vary with respirations. We see this more commonly in children than we do in adults, but it's still out there. So it speeds up a little bit when you take a breath, and then it slows down a little bit when you exhale. But it doesn't always happen, but you may see that on a strip, and don't freak out by it. It's probably within normal limits. However, if you're measuring it off, it should be at least 0.8 seconds difference between the shortest and the longest R to R intervals. Does that make sense? No? If you're measuring it off, you're looking for difference. If you measure it and it's a difference of, this far, then it doesn't meet the parameter. So for you to call it a sinus dysrhythmia, it's got to be at least 0.8 seconds difference there.
4 more?
Yes. That would be a minimum 0.8. If you have somebody that has sinus dysrhythmia, it may be in the presence of a AMI. There's something called sick sinus syndrome that can lead to some strange rhythms here. Certain drugs, anything that slows down or affects the SA node can lead to that. But sinus dysrhythmia is not a big deal. You probably won't even notice it. But if you see it on a test, you need to be able to recognize it as sinus dysrhythmia, okay? Y'all good with that? All right, here's the little sheet on that. What's the rhythm? Irregular. It's going to vary more than last one said 0.08. 0.08. I have to fix that. All right. Okay, let's look at this rhythm. Do you pick up the inspiration and expiration or the slight dysrhythmia? This is a 6-second strip. So what is this? All right, so the rate is 90. Rhythm, it is irregular. The PR, the P wave, upright, normal, present. PR interval.
That's what I'll get.
Yeah, you just measure these. You know, if this freaks you out, it's going to be between 3 and 5 small blocks. So if you count the small blocks right here, 1, 2, 3, 4, it's about 4.5 blocks. So it's on the long side, but it's within normal limits. And if that helps you just to count off the blocks, that's good too. And the QRS, the shape is upright and tight. The length, when we say tight, we're covering that. And the length is supposed to be what? Less than or equal to 0.12. Which is how many small blocks? 3. Good job. All right. Sinus dysrhythmia requires a variation of. We should all be on this one quick. Come on, chop chop. I had a countdown timer on here, but I took them off. Okay, a few more, 5 more. Ching, ching, ching. All right, 22, there we go. Should have 23. It's just on the last slide, 0.08. Because I told you the prior slide that said 0.8 was incorrect. So it's 0.08. Okay. Sinus arrest. Did y'all like my picture up there? Y'all probably didn't even see it. Okay. Sinus arrest. With the sinus arrest, the SA node doesn't do what it's supposed to do. It's just like it's on break when it's supposed to pulse. So you'll just see there's just this void in the middle of your strip. Usually, what you'll notice with sinus arrest, if you don't have an impulse coming from the sinus node, what won't happen in the ventricles? Well, there won't be a P wave. There won't be any QRS either. So you just have your normal complexes, and then you have this dead zone, and then it picks right up. So it causes a short period of sinus with cardiac standstill where there's no pulse. You know, you can't manage that for long, right? And at some point, hopefully, quickly, the sinus node will pick back up and restart. These are always scary when you see this, particularly if they've missed a couple of beats. You're going, are they going into asystole? Then it picks right back up, so you kind of go, whoosh. Okay, causes of this, you know, the usual suspects. Hypoxia is always at the top of the list. Ischemia, what are we talking about when we say ischemia here? Lack of oxygen, yeah, to the heart muscle, right. Something's not getting through there. If the SA node is damaged, or of course, certain medications, digitals, which we don't give in the field, thank goodness, and salicylates. They could, certainly. Could easily. I think that's one of the things they look for, you know, if they're... Never heard it called that, but it kind of does that. Okay, it can also be as a result of a heart attack. At this point, you're looking to see if your patient is what? Symptomatic. Yeah. Is he symptomatic or asymptomatic? Is he stable? Is he unstable? If he takes a break, he gets 2 complexes, and then it takes a break of 3 complexes, and then you get 2 more. We're going to call that what? What's the rate? Or what's the rhythm? Or the name of it? It's going to be bradycardic, right? Certainly. But if he's got that long pause, what do you think the response is going to be in the body? It's not getting enough oxygen. It's not getting enough perfusion. We don't see this a lot. I think I've seen it twice in my whole career. So, but it can be real freaky. So when you go down the 5 things, the rate, it's going to be whatever the rate is. Of sinus arrest, it's usually going to be bradycardic. It's always going to be irregular. The P waves, the complexes look good. The P waves look good. The QRS looks good. There's just this dead zone. So we're going to see a picture of it here, I think. Yeah. So it's just clicking along. And it just like drops off the planet. At least he's moving a little bit. Okay, clinical clinical significance. So this is really what we're looking for. We can identify the rhythm, and you'll have plenty of patients with these really screwed up rhythms, and they look great. They're perfusing well, they're alert and oriented, no respiratory distress, blood pressure's good, all that's good. All we're looking for is when they're unstable. If they're medically unstable, then we're going to start thinking about what we're going to do. Now for your patients that are symptomatic from these rhythms, and this is all the sinus rhythms with any type of variation, you want to identify if they're stable or unstable. They may experience chest pain. You know, they're not getting enough oxygen to the heart muscle, right? They may feel nauseated. They may feel weak. They may pass out on you. Some of these rhythms are going to be intermittent. They may come, patient feels real symptomatic, and then it clears up and they go back to a normal sinus rhythm, and then they clear up. One of the things we're always going to be looking for is the blood pressure. If the blood pressure is good, then I can manage most of these other things. But if the blood pressure is falling, that's usually an indication that they're not perfusing well, and we're going to have to get on that. So if for sinus bradycardia, this is probably one that you're going to see the patient is most symptomatic, depending on how slow the rate is. If they're symptomatic, you're going to see signs that they have decreased cardiac output. What would be the signs of decreased cardiac output? What are they going to look like? Yeah, they're probably going to be pale. Their skin signs are what you're going to start looking at. So what are the other skin signs you're going to notice? They're probably diaphoretic. They're pale. They're probably cool. Or what's going to be their mental status? Yeah, they're going to be probably anxious early on, but as it drops a lot, if they're down in the 20s and 30s, they may have an altered mental status for sure. So our treatment of these patients, if they're symptomatic, is really going to be based on how symptomatic they are. If you look in there and they've got a pulse rate of 28 and they're barely even conscious, we may skip to something a little bit more aggressive. Oftentimes, though, with a sinus brady, if you put them on oxygen, you clear up that hypoxia, they may clear up and feel fine. You're always going to want to get IV access on anybody that has any type of irregular rhythm, regardless of what it is. You're going to need IV access because you never know when you might need to use that pretty quickly. Our first drug that we're going to use is going to be atropine. Does anybody know what the dose of atropine is? Look it up in your book. Do what? You killed your patient. Okay, Bo just killed the patient. Do what? 0.5 milligrams? What page are you on? 9. I gave y'all that 9, didn't I?
0.5.
It says maximum is 3.
That thing was coming off. Yeah, you have a max. You can't give more than 3. Your first bolus, is going to be 0.5 milligrams. And remember, it's 0.5. It's not 0.5. It's 0.5. And then you can repeat that every 3 to 5. And if that doesn't work, you may consider, what's TCP? Transcutaneous pacing. And then there's some, if you look on your algorithm, you can see after that, if they're unresponsive to that, we may try some dopamine. What's the purpose of dopamine? What is its main action? We give it to do one thing in particular. Raise the blood pressure. Yeah, who said that? Okay. Yes, to raise the blood pressure. Now you need to make sure, though, before you start administering drugs, that you've got enough fluid on board. If they're dehydrated and they've gone from tachycardia and now they're bradycardic, giving these drugs is not going to fix them. They're going to need a fluid bolus. So you got to figure out what's going on with your patient. You're going to get that through what? Your history and your assessment. And if all those things don't work, you may give an epi-drip, but on the ambulance, I don't think we carry epinephrine in that form that we're going to drip it up, but I guess you probably could. I've never done it. Okay, sinus tach. Now here we're looking at treatment. So we've moved from these are the strips. Now we're going to see how we're going to treat these just briefly, so that when you go into the labs, you'll be ready. If the cardiac output falls, even if they've got 120 to 130, you may see signs that cardiac output is dropping. Why does that occur? Yep. You're not getting, the heart's not filling properly, so you're not getting good perfusion. So they may be symptomatic at 130. Sometimes we don't see it till it gets above 150, depending on your patient specifically. When the heart's beating that fast, it requires a lot more oxygen. You know, when it's, say you're normally 80, now you're beating 160, you've got twice the oxygen requirement as you did before. And you're not getting as much oxygen because it's going too fast, right? So this can lead to ischemia in the heart. It can lead to a heart attack. So our goal is going to be determining the cause of that sinus attack. And what are the causes of sinus attack? Pain, fever, anxiety, medications, hypoxia, drugs. I guess we have medications and we have drugs, right? So if you can figure out the cause of that, maybe you can alleviate that. If it's hypoxia, what do we do? Give them some oxygen, let's give them some high flow oxygen. If they're breathing inadequately, what do? We're going to bag them. How can we tell if they're breathing inadequately? Yep, rate is one. What's the other one? Quality is okay, but I'm looking for the V word. Volume, rate and volume. If their rate is out of the parameters or they're not getting enough excursion, then they're going to be breathing inadequately. All right. Sinus dysrhythmia, we talked about this. This is not a bad thing. 99% of the time, it's no big deal. You just note it, you identify it, and record it, and move on. Okay, sinus arrest, we talked about that. Oftentimes, if it's just very intermittent, the patient may not be symptomatic at all. But if it's like where you can see where it's missed several complexes, then yeah, they're going to be symptomatic. You're looking for what? Signs of what? Decreased cardiac output, which you'll see that because of altered mental status, poor perfusion, skin signs, yeah, and dropping blood pressure. So with this, with any one of your patients, with any rhythm you're looking for, are they stable? Are they unstable? And then of course, if they're stable now, are they going to be stable in 10 minutes? Who knows? So we have to be constantly reassessing our patient. So as soon as you determine that they are unstable, now you're going to start moving a little bit more aggressively. We're going to start with oxygen because hypoxia can cause sinus arrest, right? You can look on there. We've already got an IV in place because that's what we do. What drug therapy would you do for this? Yeah, probably start with some atropine. They're real symptomatic. Atropine doesn't work. We may move to electrical therapy, pacing probably. Before you use dopamine, you always want to be sure that they're properly hydrated. All right, y'all ready? I got a star there. How do you treat sinus attack? This is an easy one. Come on now. Somebody's sleeping on their clicker. Or sneezing on their clicker. Come on, a few more. No sleepers out there. You think we're going to get 100% on this one?
No.
Really? If we can figure out the cause of something and we fix it, then we don't have to move along with a bunch of other things, right? So let's see if we can figure out what the underlying cause of sinus attack is. Sinus attack and bradycardia, those are things that sometimes we can control. Sinus attack more than anything else. Once they're brady, it's hard to get them back up without something else going on. But with sinus attack, it's usually there's some issue, psychological, or it could be drugs, but if you can figure out the underlying cause, it could be they just need a fluid bolus, right? How do you get if you're shocky, if you're hypovolemic? You become what? Tachycardic usually. Isn't that the sign of shock? What are the signs of shock? Start off with sinus attack, hypotension, yeah. Skin signs, cool, pale, diaphoretic. Those are all signs of shock. Your patient's shocky, you give them some oxygen, give them some fluid, you may fix this. So you want to understand what the underlying cause is if you can and treat that before you have to move to other stuff. Okay, what I have here is a series of strips. And there are strips and a question where you identify it. Strip and a question. So I'm going to show you the strip first, and then we go to the question. I think that's where I am. So look at this strip, go down the 5 things, and see if you can identify this. You should be able to see these little blocks so you can tell. 3 blocks is 0.112. 5 blocks is 0.20. So what's the rate? Okay. Rhythm? Well, it's regular. P waves? Inconsistent. PR interval? PR interval is normal. QRS? Upright and tight. So this is what? Well, give it to me. Come on, everybody. Yoo-hoo! Yeah, I can't see a lot of variation when I look across there. And you know, you can have a slight, up to, 10% variation before it goes into sinus dysrhythmia. So this is definitely normal sinus rhythm. Even though it looks a little weird, the QRS is not really tight like some of them that we've seen, but it is within normal limits. So we're going to call that a normal sinus rhythm. Ta-da! All right, what's this? Well, don't say it out loud. I want you to look at it, and then we'll bring it up next on the next slide. Go through your 5 parameters. Okay, y'all. You know what this is? Who called that normal sinus rhythm? Several of you did. It's too fast to be a normal sinus rhythm. Hey, I'm going to tell you one thing right now, because when you get to like your last semester and we start going through strip analysis and stuff, one of the biggest things I see mistakes that students make is they forget that a tight QRS is above the ventricles. If it's wide QRS, where this little thing is really wide, then it's going to be a ventricular rhythm, okay? So don't call this VTAC. Nobody here did today, but this semester is young yet. Sinus tach. All right. I think all of these are 6-second strips from here on out. Identify. You could, if this thing was slid over a little bit, you'd call it a sinus rhythm, I think. But technically, we've got sinus brady here. All right. Let me look at it there. Is it easier to see there? You can see the blocks. All right, what's this? Come on, make a stab at it. Who's not playing? Yeah, here. Is this because it dips down like that, that doesn't make it dysrhythmic. But if you look at the R to R, it's shorter here than it is the rest of the way. If you kind of just glance at it as a whole, you can see that this interval is shorter than here and here. Couple more. Top, top. You haven't voted, get after it. Good job. Now, one thing I do want to point out, because when we look at heart blocks a little bit later, I don't want you to be confused. This interval here, you don't have to superimpose one in here and it has to be regular. It could be any length, just you know that one's dropped. Does that make sense? Some of the rhythms we're going to look at later, if one's dropped, it's still going to be really regular, so one would fit right in there without interrupting the rhythm. Here, it's going to be irregular. It's not going to be the same every time. That makes sense? Probably not. All right, here's one for you. Y'all know this. Y'all are stalling. Y'all don't want us to go to the next chapter. Come on. If you hadn't voted, get after it, guys. We're all waiting on you. Up top. Who called that sinus breathing? We've got some math issues, I can tell. For those of you that pick normal sinus rhythm, surely you can see the difference in this and the difference in this. That's quite significant. So that makes it sinus dysrhythmia. All right, what's this one? Oh, you want me to back up? You can see it. You know if you pick the wrong thing, if you re-click it with the right one, it corrects it. It's not playing. Okay. Yeah, y'all are disturbing me here. Ventricular tachycardia, for it to be a ventricular rhythm, what does that QRS gotta look like? A big old fat nasty, yeah. There's no kind of big old fat nasty on there, so it cannot be any kind of ventricular rhythm. All right. Okay, what's this one? Who's picking D? I'll see you after class. Come on, rest of you guys, pick one. I put these things together. That isn't the answer I would have put. I don't really see the dysrhythmia. Do you all? Unless it's right.
No, but the other one.
Right here.
Definitely.
Yeah, this is too close. I'd have to call that sinus rhythm. I was looking, I'm going, where's the normal sinus rhythm?
The
I
first
would have
one's
to-
longer than any other,
Yeah.
and then I guess the fourth one's long.
Yeah, it's pretty close though, isn't it? If you just look at it, I guess if you measure it out, you might call it dysrhythmia. Yeah, that's what I called it. Because you got a little bit of variation, but maybe that first complex between the first two is it. All right, what's this one? Man, I'm going to put some tape over some mouths. I'm going to enjoy it. Been a long time coming.
I think basically very, she put me in the KU, you got to take my hand, you got to put this bottom.
Didn't let you out. Who called this normal sinus rhythm? What does it have to be normal sinus rhythm? It's got to be at least 60. It's not. That's sinus breathing. All right, what's this? This could be a symptomatic patient. The pause? From dysrhythmia in the rest? I would probably say more than one of the normal complexes, the normal R to R. If you're missing, oh, we all voted, I'm sorry. It didn't say 100%. What's up with that? This is definitely sinus arrest. How many complexes are missing, you think? Yeah. Yes. Maybe 3, 2.5. So yeah, this patient could be symptomatic. Ta-da! Now at this point, last semester we weren't short of time, so I had you work in your workbooks. We've got time to do the next chapter. We all get up and take a break and then come back, about a quarter after, and let's hit the next chapter, okay?